everyone, and welcome to our Plasminogen Deficiency session. My name is Julie, and I work from Promedic under the Rare Disease Division. We are pleased to have Dr. Nakar with us today, who will be presenting a few case studies of patients suffering from plasminogen deficiency. Dr. Nakar has many years of experience helping patients dealing with this rare disease. I will leave you now with Dr. Nakar. Thank you very much for your participation, and we hope you'll enjoy this presentation.
Thank you. I wish to thank the audience for their interest in this webinar. I will focus on clinical cases of patients affected with congenital plasminogen deficiency. Before I present the clinical cases, I would like to provide a brief overview of background, clinical manifestations, diagnostic challenges, and historical treatments. Activated plasminogen turns into plasmin, which is the enzymatic component of the fibrinolytic system and is the main enzyme involved in lysis of clot and fibrin clearance. It also converts Latin matrix metalloproteinases into the active form, which degrades extracellular matrix as part of wound healing. Plasminogen is synthesized primarily by the liver, but is also produced in other organs. Two primary forms exist which differ in the N-terminal substitution. Gluplasminogen is the major form and has a half-life of about 2.2 days. It converts to Lis-plasminogen, which is the minor form in the blood and has a shorter half-life of about 0.8 days. Levels vary little throughout adult life. There are two types of plasminogen deficiency. Type 1 plasminogen deficiency or hyperplasminogenemia is a quantitative protein deficiency with decreased plasminogen activity and decreased antigen. It is a multi-organ systemic disease, often presenting as ligneous conjunctivitis. Type 2 dysplasminogenemia is characterized by normal or near normal antigen levels with reduced functional activity. Those patients are usually asymptomatic, even with very low activity level. Type 1 plasminogen deficiency is an ultra-rare autosomal recessive disease caused by defects in the plasminogen gene on chromosome 6, which results in decreased plasminogen activity and antigen levels, leading to impaired extravascular fibrinolytic activity, impaired wound healing, and extravascular fibrin-rich, what we call woody lesions, may impair the organ function. It is a systemic disease with multi-organ involvement, including eyes, ears, nose, oral cavity, including gingiva and tonsils, sinuses, GI, and genitourinary tracts, as well as the respiratory system, including the airways and lungs, and rarely CNS. Untreated, plasminogen deficiency may result in significant morbidity, reduction in quality of life, and in some cases may be life-threatening. Ligneous conjunctivitis is the most commonly diagnosed clinical manifestation. The prevalence is estimated to be 1.6 per million. There is extensive heterogeneity in the clinical manifestation. Patients may experience a variety of lesions which differ in location, size, and organ system. Currently, we are unable to predict disease severity or the course based upon plasminogen level or the genetic defect. Prognosis varies depending on site, extent, and duration of lesions. The disease may result in visual impairment or loss of gingiva or dentition, collapsed lung or respiratory failure, renal failure, dysmenorrhea, infertility, hearing impairment or loss, and rarely hydrocephalus. Although thrombosis reported an initial case of plasminogen deficiency, it does not appear to be a symptom of the deficiency. The eyes are the most common affected organ, and ligneous conjunctivitis accounts for about 80% of the clinical presentations. This is followed by oral cavity involvement, mainly ligneous gingivitis, the respiratory tract, including larynx, vocal cords, and the tracheobronchial tree, then the ears and the female genitourinary tract. Less common are the renal system, CNS, and skin, although again, involvement may result in significant impairment. Here are a few examples of clinical manifestations. On the upper left, an example of poor wound healing. On the lower left, a typical ligneous conjunctivitis. In the middle, left lung collapse, secondary to area obstruction by ligneous lesion, as shown on the lower slide. On the right is an example of ligneous periodontitis. Ligneous conjunctivitis presents as thick, woody conjunctival growth, typically preceded by erythema and chronic tearing, followed by the development of white, yellow-white, or even red masses. The pseudomembranes are more likely observed on the upper eyelid. Bilateral involvement occurs in about 2/3 of patients. The growth is often triggered by local infection or an injury. Ligneous conjunctivitis typically recurs after surgical removal, and it is observed across all patient age ranges. Lesions may be present for variable time. Reported cases range from few months to 44 years. Corneal involvement occurs in about 1/3 of cases and may result in visual impairment or even visual loss. Surgical removal of lesions, although initially helpful, typically result in acceleration regrowth of the pseudomembranes. Multiple medical therapies reported for treatment, usually individual case reports, are not consistent to show efficacious. FFP is reported to have some success, but the low concentration of plasminogen in FFP resulting in an ineffective or inconsistent ability to achieve therapeutic levels. In addition, FFP may lead to volume overload and other adverse events. Plasminogen concentrates, topical and systemic, utilizing the LIS plasminogen, have been reported to have efficacy. Currently, no specific licensed therapy is available. There are 2 products in development by 2 different companies that have demonstrated promising results. One is the plasminogen eye drops, and the second is the IV glue plasminogen concentrate. The following clinical cases were taken from the patients treated with the IV plasminogen concentrate to demonstrate the wide array of symptoms that patients may experience. The first patient is a 37-year-old Caucasian female, diagnosed at 14 years of age with baseline plasminogen activity of 4%. Her past medical history is significant for multi-organ involvement. Both eyes were affected by ligneous lesions since 2 years of age, with history of multiple surgical removal of lesions and multiple medications, including FFP eye drops. In addition, she experienced periodontal disease receding gum line with nerve exposure, for which she underwent multiple scaling and root planing. Her sinuses were involved, requiring surgical removal of lesions. GI involvement resulted in chronic gastric ulcer and gangrenous cholecystitis. She suffered from genitourinary involvement as well, with renal parenchymal masses observed on ultrasound and blocked fallopian tubes, cervicouterine lesions, and painful intercourse and dysmenorrhea. Above all these, the respiratory tract involvement was the most severe. She experienced tracheal obstruction, recurrent, and then permanent right upper lobe collapse and severe bronchiectasis, and underwent numerous laryngotracheobronchoscopies for ligneous membrane removals due to respiratory distress, obstruction, and hypoxemia. Upon enrollment in the IV Plasminogen study, she was found to have small lesions over a right upper eyelid, lesions over the right inferior turbinate, gingivitis presented by the white plaques, and on exam, she had diffuse bronchi with left mid-lung late inspiratory wheeze. The slide on the right demonstrates the abnormal right upper lobe prior to current permanent atelectasis. Shortly after the first infusion of IV Plasminogen concentrate, breathing effort and depth reported to improve, and within few hours post-infusion, mucus plaque was expectorated, and she developed gross hematuria with mucus-like debris which cleared thereafter. Upon enrollment, both kidneys were involved. Left kidney showed a large, ill-defined 2.7 centimeter hyperechoic area within the parenchyma at the junction of the upper and mid pole. At 12 weeks of IV Plasminogen therapy, the left kidney showed significant improvement in the appearance of the lesion. After 12 weeks on therapy, lung CT did not reveal changes in the right upper lobe collapse. On the other hand, her clinical status greatly improved without chronic cough or use of nebulizers and increased physical capacity. Four weeks after she began therapy, her spirometry showed significant improvement, with FEV1 increased from 46% to 91% of predicted value. In summary, this patient exhibited multisystem affected with manifestations of plasminogen deficiency, including ocular, ENT, oral, respiratory, gastrointestinal, and genitourinary. At study entry, pulmonary status was life-limiting and severe. Treatment resulted in clear clinical improvement, most notably in the respiratory status. Currently, the patient does not require the use of inhalers and is without chronic cough, with increased physical capacity and significantly improved quality of life. The second patient is a 25-year-old Caucasian female diagnosed at 2 years of age with a baseline plasminogen activity of 29%. This patient again had past medical history of multi-organ involvement, including eyes, genitourinary, oral, nasal cavity, and respiratory system. In comparison to the previous patient, I would like to emphasize the following. This patient had recurrent ligneous tonsillitis with prolonged hospitalizations and IV FFP therapies due to difficult eating and swallowing. And in addition, she had involvement of vocal cords with chronic hoarseness up to a degree of losing her voice temporarily around 20 years of age. In those slides, one can appreciate the ligneous tonsillitis, which may resemble infectious tonsillitis. On physical exam prior to starting IV plasminogen therapy, she was found to have significant periodontitis and gingivitis with large lesions, as demonstrated in the slide. Two weeks into the IV plasminogen therapy, she experienced an episode of tonsillitis, which rapidly responded to the scheduled infusions. Looking at the slides from left to right, one can appreciate significant improvement within hours after infusion and near complete resolution by the next day. At 6 months from enrollment on scheduled IV plasminogen concentrate therapy, the patient had no further episodes of conjunctivitis, had not utilized bronchodilators for asthma, reported normal menses with resolved dysmenorrhea. She has not required pain relief medications. GYN follow-up revealed normal uterus, endometrium, and ovaries. Colposcopy revealed normal cervix. Gingival lesions resolved as well, and no vocal cords or nasal lesions were identified. Her voice was strong, and she was able to speak normally. The third patient is a 5-year-old Caucasian female diagnosed at 5 years of age with a baseline plasminogen activity of 16%. Her main symptoms were primarily right ligneous conjunctivitis, observed at 9 months of age, for which she underwent several excisions and multiple topical modalities. In addition, she did have reported microscopic hematuria, and on follow-up, she was found to have lesions on her vaginal wall. As reported previously, surgical removals of lesions without adequate therapy results in rapid reforming of ligneous lesions. The slides demonstrate how quickly and sometimes aggressively the lesions form after surgical removal. Here we see the lesions 1.5 weeks prior to removal. Here is the same patient 2.5 weeks post-removal and 3.5 weeks post-removal. On the right side is how the eyes look after different excision of lesions. Interestingly, some patients or parents report that symptoms can be appreciated within hours after surgical removal. After 3 weeks on IV plasminogen therapy, significant improvement with near resolution of lesions was demonstrated. After 6 months on therapy, ligneous lesions resolved with no evidence of recurrence. At 12 weeks of therapy, vaginoscopy did not reveal significant changes with persistent adhesive ligneous band and membranes, but on long-term follow-up, lesions gradually resolved. The last patient is an 18-month-old Caucasian female diagnosed at 3 months of age with baseline plasminogen activity of 12%. Her past medical history includes recurrent ear infections and bilateral ligneous conjunctivitis, starting as early as 3 weeks of life. Initially as non-specific epiphyseal symptoms, followed by pseudomembranes. Multiple topical modalities and surgical removals failed to achieve remission. At 5 months of age, she began therapy with IV FFP with temporary relief. Around 8 months of age, she began therapy with plasminogen concentrate eye drops, which demonstrated significant improvement with resolution of lesions after surgical removal of residual hard lesions. Here are the eyes before starting therapy with significant improvement. Some of the lesions are very hard and stubborn, and after surgical removals, if you continue therapy, they reach full remission. At 16 months of age, the family reported URI symptoms and febrile illness, resulting in exacerbation of ligneous conjunctivitis, an ongoing wheezing and stridor, which did not seem to respond adequately to bronchodilators and steroids. She was found to have upper airway inspiratory and expiratory stridor and elevated respiratory rate, which prompted a stat evaluation by a multidisciplinary team. Her evaluation revealed hypercapnia, narrowing of mainstem bronchi on CT scans, and copious amount of fibrinous material in the airways, with very friable airways on bronchoscopy. She began stat therapy with IV FFP. The following slides, taken during initial bronchoscopy, reveal significant involvement of all levels of the airway, including the glottic and subglottic with edema, upper trachea, carina, and right main bronchus with ligneous plaque lesions narrowing the airways. Imagine having to breathe through a straw. This, by all means, is a life-threatening complication of plasminogen deficiency. As mentioned, stat IV FFP therapy was initiated, and plasminogen concentrate eye drops were discontinued. Compassionate use of IV plasminogen concentrate was approved, and she began aggressive therapy, which was subsequently weaned to maintenance dose regimen based on clinical improvement. Port was placed on day 10 of admission. Repeat CT scan around day 10 demonstrated significant improvement with near resolution of membranes. Bronchoscopy around the same time demonstrated improved friability, mild to moderate edema in the right and left bronchial tree, and no evidence of membranes. The patient was discharged home after 2 weeks on home IV therapy, since she had no further clinical respiratory symptoms. The two slides at presentation and 10 days post-initiation of therapy clearly demonstrate the significant improvement in this life-threatening complication of plasminogen deficiency, with resolution of ligneous plaque-like lesions in the airways. In summary, this patient presented with initial involvement apparently limited to ligneous conjunctivitis. Lesions improved with adequate topical plasminogen eye drops. Subsequently, she developed respiratory symptoms that persisted, progressed, and became life-threatening. The lesions in the airway tree and the associated symptoms resolved with systemic administration of plasminogen concentrate. To conclude, Plasminogen deficiency is a very rare disorder characterized by decreased activity of the pivotal zymogen of the fibrinolytic system. Disease may wax and wane over time with variable manifestations within and between affected individuals. Currently, we cannot predict who will develop symptoms or where symptoms may occur based upon levels or genetic defect. Plasminogen deficiency is a multi-system disorder manifested by the development of fibrin-rich or ligneous lesions, largely in the extravascular sites. Ligneous lesions interfere with organ function, depending on the area affected, the size, the lesion chronicity. Deficiency may result in severe consequences, including impairment or loss of vision, hearing, voice, respiratory capacity, fertility, renal function, hydrocephalus, etc. Mortality may occur. Recognition of manifestations is a critical first step. Novel therapies hold hope for the future. Last but not least, an international plasminogen deficiency study will provide much needed information to help patients and clinicians predict the course and develop tailored treatment regimens. The website of the study is on the slide. I wish to thank the audience again for participating in this webinar. Thank you.